The goals of diabetes management are to eliminate symptoms of hyperglycemia, prevent complications, and maintain a near-normal lifestyle. Symptoms usually improve when plasma glucose falls below 200 milligrams per deciliter. Avoidance of hypoglycemia is a critical component of safe diabetes care. Diabetes care must be individualized, patient-centered, and multidisciplinary. The patient plays the central role along with physicians, educators, nutritionists, and specialists. Key elements include glycemic targets, glucose monitoring, lifestyle management, and complication screening. Hemoglobin A1C should be measured 2 to 4 times per year, depending on control. Lifestyle management includes structured diabetes, self-management education, and support. Nutrition therapy emphasizes nutrient-dense foods and limits refined carbohydrates and added sugars. In type 2 diabetes mellitus, weight loss of 5 to 10% significantly improves glycemic control. Physical activity of at least 150 minutes per week reduces insulin resistance and cardiovascular risk. Patients with type 1 diabetes mellitus must monitor glucose before, during, and after exercise to prevent hypoglycemia. Psychosocial care includes screening for depression, anxiety, and diabetes-related distress. Continuous glucose monitoring measures interstitial glucose every 5 minutes and provides time in range. Hemoglobin A1C reflects average glucose over 2 to 3 months and guides long-term control. General glycemic target is hemoglobin A1C less than 7% for most non-pregnant adults. More stringent targets of 6.5% or less may be used in selected low-risk patients. Less stringent targets of 7.5 to 8.5% are used in elderly or high-risk individuals. In type 1 diabetes mellitus, therapy aims to mimic physiologic insulin secretion with basal and prandial insulin. Total daily insulin dose ranges from 0.4 to 1.0 units per kilogram per day. Basal insulin provides 30 to 50%, while bolus insulin provides 50 to 70% of total dose. Rapid-acting insulin is given less than 10 minutes before meals to control postprandial glucose. Long-acting basal insulins such as Glargine and Degludec provide steady glucose control. Insulin pumps and automated insulin delivery systems improve time and range and reduce hypoglycemia. In type 2 diabetes mellitus, metformin is the preferred first-line agent. Sodium glucose cotransporter 2 inhibitors reduce heart failure and chronic kidney disease progression. Glucagon-like peptide 1 receptor agonists promote weight loss and reduce cardiovascular events. Sulfonylureas increase insulin secretion, but carry risk of hypoglycemia and weight gain. Thiazolidinediones improve insulin sensitivity, but may cause edema, heart failure, and fractures. Insulin therapy in type 2 diabetes mellitus is indicated in severe hyperglycemia or catabolic states. Basal insulin is usually started at 0.1 to 0.4 units per kilogram per day. Combination therapy is often required as type 2 diabetes mellitus progresses. Hypoglycemia is the most serious adverse effect of therapy, especially with insulin and secretagogues. Diabetic ketoacidosis is defined by hyperglycemia, ketosis, and metabolic acidosis. It typically occurs when glucose exceeds 250 milligrams per deciliter with elevated ketones. Management includes fluid resuscitation with 2 to 3 liters in the first 1 to 3 hours. Intravenous insulin is given at 0.1 units per kilogram per hour infusion. Electrolytes, especially potassium, must be closely monitored and replaced. Hyperglycemic hyperosmolar state, presence with extreme hyperglycemia, above 1,000 milligrams per deciliter and dehydration. Management requires aggressive fluid replacement and insulin therapy. In hospitalized patients, target glucose is 140 to 180 milligrams per deciliter. Clinical takeaway is that effective diabetes management requires integrated lifestyle, pharmacologic, and complication-focused strategies.